Hello, ma'am. Good evening.
Hi, good evening.
Yeah, hi, good evening. Thank you, Manisha, for joining. हाँ,
रितु जी नमस्ते। क्या
नमस्ते
हाल है?
नमस्ते, कैसे हो आप? ठीक हूँ।
मत-
हाँ, क्या होता है, जिस दिन वेबिनार रखती हूँ उसी दिन पेशेंट लेट करता है। इतना भागते हुए आई हूँ। जब आपको मैसेज डाला तब चलाते, गाड़ी चलाते चलाते इसकी तब से सोच रही थी, डाल रही हूँ एकदम भाग भाग कर।
No, you should always
तो
drive safe.
हाँ, या अच्छा, Manisha, the flow is like that. First, Namrata will introduce you and me. Then I
Hmm.
will start taking the questions. And meanwhile, whatever the questions we will receive live, that will be visible to you also in the chat box.
Okay,
Huh?
ठीक है।
Related to five. Yeah, yeah.
तो वो चैट बॉक्स भी मुझे खोलना पड़ेगा। एक
नहीं,
सेकंड
दिखेगा ना, ऐसे ही
हाँ,
दिखेगा ना, इसमें दिखेगा ना।
ठीक है। I've logged in from my phone. I haven't put my laptop on.
हाँ, तो ठीक है, नो प्रॉब्लम, फोन में भी दिखेगा, फोन
हाँ,
में भी दिखेगा।
And I'll read out to you as well, ma'am.
yeah, I think that'll be nice.
हाँ हाँ, मैं भेज भी देती हूँ।
So this is इंग्लिश में ही बोलना है या हिंदी में भी बोल सकते हैं?
ऑफकोर्स बोल सकते हैं हिंदी में भी। हाँ, हिंदी इज आवर नेशनल
I
लैंग्वेज,
don't know
ऑफकोर्स
what
बोल
your
सकते
audience is like. Your audience is a mix of everyone, or is it
हैं।
just for the medical community?
मोस्टली मेडिकल कम्युनिटी।
Okay, ठीक है.
हाँ,
No, because
करेक्ट
I've
ना
seen you
नम्रता?
explain in Hindi also. That's why I was wondering.
हाँ हाँ, तो मिक्स लैंग्वेज में बात कर सकते हैं, दैट विल कैच अस मोर ना, ब्रिंग्स मोर क्लोजनेस टू द ऑडियंस।
I know.
दैट्स माय फीलिंग, मुझे ऐसा लगता है कि अगर मिक्स में बोलेंगे तो दैट विल ब्रिंग मोर क्लोजनेस।
That is true. That is true.
चलिए,
Because that's
कॉन्ग्रेचुलेशन और मैनी मैनी कॉन्ग्रेचुलेशन मनीषा। हाँ, मैनी मैनी कॉन्ग्रेचुलेशंस टेडेक्स स्पीकर। और
thank
भी
you,
क्या क्या
dear.
क्या क्या करते थे, मैं देखती रहती हूँ। हाँ हाँ, उस पर तो लिखती हूँ मैं कमेंट जब देखती हूँ। हाँ हाँ हाँ।
I know you're a very, very dear friend, Ritu. You have been always.
थैंक यू थैंक यू।
और
हाँ,
बाकी केरो हाल है? All good?
ठीक है ठीक है, अरे यू कैन स्पीक। अच्छा, आंटी सिंधी ना, आंटी सिंधी ना, मॉम ना,
Mom.
है ना? या सो
Ma'am,
यू
can you
कैन
speak
स्पीक कन्नड़ा ऑल्सो?
Yes, I can
हाँ, यू
speak
कैन,
Kannada.
या
Telugu?
टेक इट लाइक माइंडेड। हाँ हाँ,
Okay.
यस यस यस।
Yes, we are live now, ma'am. Good evening, everyone. I'm Namrata Madish from Medisage E-Learning Private Limited, a leading platform dedicated to empowering medical professionals through knowledge sharing, expert insights, and digital innovation. And today, I welcome you all to yet an insightful Medtalk on managing fibroids in reproductive years, balancing relief and fertility. We are honored to have two distinguished speakers with us today, Dr. Ritu Santwani and Dr. Manisha Singh. Dr. Ritu Santwani is a renowned obstetrician, gynecologist, infertility specialist, and sexologist, known for her holistic approach to women's health. She holds prestigious qualifications including MBBS, MD, FECOG, FIAOG, and ART Singapore. She is the founder and CEO of 360 Degree Healthcare Studio, NUHS Singapore, a platform dedicated to comprehensive women's wellness. Recognized among the top 50 most influential doctors on social media, Dr. Santwani is also the co founder of MAAM and a board member of SWWC, where she actively contributes to advancing women's health and empowerment on a global scale. Joining her today with us is Dr. Manisha Singh. She is a DM in Reproductive Medicine, UK, FRCOG, MRCOG, and currently serves as the Additional Director of Reproductive Medicine and Surgery at Fortis Hospital, Bangalore. Dr. Singh brings rich global experience, having previously served as a senior subspecialty consultant at St. Mary's University Teaching Hospital, Manchester, UK. She is an alumnus of LDMMC and came Mumbai, as well as Leeds and Cambridge, University, UK. Her core areas of interest include infertility and assisted reproduction, minimally invasive and robotic surgery, PCOS, and adolescent gynecology. She has several publications to her credit and is also a TEDx speaker. We are truly privileged to have her join us today. Welcome, Dr. Manisha. Experts,
Thank
we
you.
welcome
Thank you so
you.
much.
To
Thank you. Very kind. Thank you.
Yes, we welcome you to the session, and I now request Dr. Ritu to take the session forward. Over to you, ma'am.
Yeah. Thank you, Namrata, and thank you, Medisage, for providing the platform for such academic initiatives. Really, we are honored to have my dear friend, Dr. Manisha, is with us. Manisha, I know your schedule is very, very hectic, and even though you have taken up time for this knowledge sharing platform, so really that's amazing. So thank you once again for joining us.
Pleasure
So
is
friends,
all mine, Ritu. Thank you for having me. Thank you.
most welcome, most welcome. So friends, as we all are aware that today's our topic discussion is focused on the fibroids. So related to all gynecologists, there are multiple queries related to fibroids. So I'm coming to the first and common query of related to the fibroid and infertility. Dr. Manisha, I want that you should speak something about that. That how come the fibroid, which fibroid is having the causing the most infertility related to that. Huh.
So, first and foremost, I'd like to say that fibroids are absolutely benign tumors of the uterus. And 1 in 3 women coming to my OPD have fibroids. Now, majority of the fibroids are incidental findings. So we just do a scan and we find a fibroid. Now, the fibroids typically start growing within the muscle of the uterus, and then they can either grow inwards and become submucous, or they can grow outwards and become subserous. Now, if you look at fertility, where does an embryo implant? Inside the endometrium. So a fibroid that's going to impact the implantation of a pregnancy, first and foremost, would be a submucous fibroid. Now, depends on how big or small a fibroid is. That's how we define whether we need to do something about it or we can leave it alone. So the first fibroid that would concern us would be a submucous fibroid, a fibroid polyp that is jutting into the endometrial cavity. There may be subserous fibroids that may compress a tube somewhere, but most of the intramural and subserous fibroids we leave alone. So I hope that answers your question, that it is the submucous and the fibroid polyps that worry me the most.
Correct. So now related to fibroid, so you think which diagnostic modality is the best? So we have to go for, yes, of course, in the ultrasound, we are able to see some of the fibroids. So you think that what is the criteria for choosing the ultrasound versus MRI, and in which patients you think that hysteroscopy is the must to diagnose?
So ultrasound is like doing, an internal examination. What we used to do a per vaginal examination in the good old days when we didn't have ultrasound, and transvaginal ultrasound has just become an extension of that. So it's a tool that every gynecologist has in their office today. So ultrasound is the first and foremost. And if you are a good sonologist, I don't think you need to do anything more in terms of diagnosing a fibroid. But yes, if you are going to do a hysteroscopy, then I prefer the see and treat modality. So I don't just see a fibroid and say, Ki Baba, you have a fibroid. And next time we'll do something about it. So if you are interested in making the woman pregnant, then you will see and treat at the same time. So yes, hysteroscopy becomes the next thing. Of course, if there are very large fibroids, they are compressing on the other visceral organs, like, for example, their ureters are getting compressed, then yes, you have to do an MRI with a contrast. And then, that's where really an MRI comes into play. But for a routine infertility case, we don't generally resort to doing MRIs because ultrasound today is exceptionally good. You can combine a transabdominal with a transvaginal if you have multiple fibroids, and you can do the needful. But yes, if there is other involvement, like sometimes you see fibroid with endometriosis, which is not at all
Correct.
uncommon. So yes, in
Hmm.
those cases, you will need an MRI. But the great majority where you are going to do a scan and you're a good sonologist or you have a good sonologist, you don't really need to do an MRI. And a lot of women are claustrophobic in the MRI machine, so they may not really be
Correct.
happy to lie
Correct.
inside for 45 minutes, and go clank, 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 clank going in their ears. So they don't want to hear that.
Correct. So very nicely you have pointed out, yes, with the invention of the good sonography machines and the good sonologist. And of course, if we are trained in that, then we can also do. And these days, the 3D images are also creating a wonderful impact
Yes,
on that. Yeah.
yes, yes,
Yeah.
correct.
So thank you for that. So now, as you have just told that the fibroids are mostly benign. So is it like that if the fibroids, because this is the very common questions usually the PG students also ask, okay, madam, what happen if we are not treating the fibroid? If we are leaving the fibroid as such, what will happen? This question actually we have received just now. So that's why I'm taking it.
So as I said, if I see a woman with multiple intramural fibroids, I do absolutely nothing. As long as she has got patent tubes, the uterus is not hugely enlarged, and she's got a good egg reserve, and the sperm parameters are good, you don't have to worry the patient by doing a surgery. Yes, if she has tried, she has, failed to get an implantation, she's had multiple miscarriages, she's got heavy bleeding, then yes, I will treat a submucous fibroid. Or if there are multiple fibroids and the whole cavity is distorted, say you want to do an IVF cycle and you can't even reach the ovaries because the ovaries are so high up because the uterus is enlarged, then yes, you will treat those fibroids. But generally, you have so many women who have 4, 5 fibroids intramural and they're not encroaching into the endometrial cavity. Tubes are perfectly patent. You just leave them alone. You don't treat all the fibroids. I mean, if you look at the African women, they have very good
Yeah.
fecundity, and 75 to 80% of African women have multiple fibroids.
Yes,
And they
yes,
have
yes.
so many children also without any problem. So it's not necessary that if you have fibroid, that's equal to infertility. Not at all. And as I said, the first thing, most of them are incidental finding.
Correct, correct, correct. So, yeah, very rightly you have pointed out. So, now coming to the another question, if as we all know, the red degeneration of the fibroid during pregnancy. So, what is your line of treatment in that cases?
Very conservative management. First of all, you tell a patient. So when you know a woman with a fibroid is getting pregnant, it's important that you counsel her. And you tell her that as the blood flow increases to the baby, so does it to the fibroid, because that's another baby that you're harboring inside. And there will be red degeneration, and that will cause pain in the fibroid area. So hydration and simple paracetamol is all that needs to be done. But if you counsel them well, most of them tolerate and they get on with the paracetamol, simple analgesia and hydration. That's about it. Nothing much needs to be done with the fibroid.
Correct, correct. Namrata, will you take a question which has received online? You are able to see? Before Namrata is checking for the questions, so if the patient has gone for the fibroid surgery, the multiple fibroid surgeries, so is it changes the route of delivery also, normal versus cesarean? This is the question we have received.
I mean, definitely if somebody's had multiple size fibroids removed, there will be multiple scars on the uterus. So
Yeah.
whether you like it or not, most of us would deliver the patient electively by a cesarean. And you would also keep a close watch on these patients because of the risk of scar dehiscence, because you don't know how it has been sutured, where the scars were. So yes, you would want to monitor these patients closely, take them as much close to term and do an elective CS. But again, you must remember
Correct.
that these are not going to be easy cesareans. They are going to be extremely challenging cesareans because there will be
Correct.
scarring. Getting an entry into the abdomen itself will be difficult. And if the woman has grown more fibroids after the myomectomy, and they come in the way of your incision, you should be prepared to do an up and down vertical scar on the uterus, the classical cesarean. And it may be that when you're closing the uterus, if any fibroid is coming in the way, as much as we don't want to touch fibroids during section, we may have to do a myomectomy so that at least you can suture the whole scar correctly.
Correct. Thank you so much. Now, one or two questions Namrata will take. We are receiving a lot of questions. Yeah, Namrata, you can take one question, my dear.
Yes, ma'am. So, ma'am, the first question we received is, how do you approach fibroids in women with autoimmune conditions or clotting disorders who are seeking fertility treatment?
Sorry, I lost you.
May I read it once again?
Yeah. Okay. I am seeing the question.
Yes.
So, I mean, it is going to be, a multidisciplinary approach when you treat women with fibroids and they have hematological problems. You will need the involvement of a hematologist, and depending on what the problem is, you're going to have to approach it accordingly. And it depends on what the patient's aspirations are in terms of, is she desirous of fertility or otherwise. So yes, clotting disorders and fibroids is going to be a difficult combination. In fact, I had a patient who had a fibroid that led to a deep vein thrombosis, a large fibroid, and then she needed to get the blood thinning agent. And unfortunately, that she started hemorrhaging. So then we had to not put an IVC before we operated on her. So it was not a very easy kind of surgery. So yes, you need a multidisciplinary team approach in such patients.
And the next question we received is, ma'am, ever had a case where the ultrasound says one thing and MRI says something else? Which one do you trust more for fibroid mapping before surgery?
You have to take the input from both, and finally, when you go inside, you have to see with your own eyes when you do a laparoscopic approach or you do a robotic approach or whatever approach, open approach, whatever you're going to do, you're going to have to see for yourself. So yes, you map ultrasonically as well as with the help of an MRI when there are multiple fibroids. And finally, you have to see what is going to be the safest approach for the patient and what is the level of expertise you have as a surgeon to deal with the fibroids that the patient has. So all of these things need to be taken into consideration when you're dealing with fibroids.
Okay, ma'am. And the next question is, in patients with both PCOS and fibroids, which one do you treat first when fertility is the goal?
I mean, it is not necessary that if somebody has polycystic ovaries, they are going to be infertile. India has 60% women with polycystic ovaries, and our population is 1.4 billion and increasing. So not everybody went for fertility treatment. But yes, if it is anovulatory infertility with just some stray fibroids here and there, you would go with the anovulatory infertility treatment first, and only if the fibroids are getting in the way would you do something about the fibroids. But it is not necessary that every fibroid that you see needs to undergo a surgery or some kind of therapy. So anovulatory infertility is what you would go with first.
Ma'am, the next question is, what is your cutoff size for a fibroid where you say like, okay, this needs to come out before we think about pregnancy?
There isn't a real cutoff. I mean, I have a patient at the moment who has two large fibroids, 10 centimeter and 8 centimeter, and she was having pressure symptoms and she also wanted to conceive. So we had discussed about doing a laparoscopic myomectomy. And while she was waiting for a period to start so that I could do her lap myomectomy immediately after the period, she came back with a positive pregnancy test. And today she is 32 weeks pregnant and she's doing absolutely fine. So even with large fibroids, people can conceive, and whatever you think that, okay, I'm going to take it out and do something about it, it may not be required whatsoever. So as I said, that unless they are really in the way of someone's fertility, the size of the fibroid doesn't really matter unless they have compression symptoms, unless they are developing blood clots in the leg, or they're developing hydronephrosis. Then yes, you need to operate on these patients. But everybody that has a fibroid that walks in through the door doesn't need a surgery.
The next
Very-
question is, as you are also into robotic surgery, do you see a role of robotic assisted myectomy in improving outcomes?
Definitely, because of the precision and the 3D view of a robo, it really helps, especially, when you are suturing and giving the patient a really neat scar. It makes a huge difference. But when it comes to morcellating a fibroid, you still have to go back to the laparoscopic route and put the fibroid into a bag and morcellate, do an in-bag morcellation. So the first part of the surgery is robotic, and it definitely helps, especially when it comes to the vision, the excision, as well as the suturing. And the faster recovery time. I mean, most robotic patients, they are up about and mobile the very next morning. So, faster recovery is another additional benefit point for the robotic surgery.
Yes, ma'am.
So before the Namrata take the another question, this one question just now we have received via WhatsApp. Madam, please put some comment about the recurrence of fibroids post surgery. What's your experience and how to deal the cases?
So recurrence is not at all uncommon because the food for fibroid is a good blood supply to the pelvis and estrogen hormone. So jab tak ovary zinda hai and estrogen is pumping in, the fibroids will grow. When you do a myomectomy, it is not possible to remove all the fibroids. Many a time seedling fibroids get left out and the fibroids will grow over a period of time. And as I said, it is not necessary. So it is not uncommon to see fibroid recurrence. And it is not necessary, once again, to remove fibroids just because there is a recurrence, unless they are coming in the way of something or they are causing pressure symptoms. So, yes, if that answers the question.
Yes, thank you. Yeah, Namrata, you can take next.
Yes, ma'am. Post myectomy, how long do you recommend waiting before attempting for conception?
So post myomectomy, I generally say you must wait for 6 months till everything heals. But while you are waiting for that 6-month period, say somebody also has blocked tubes or something, after 3 months, you can still do an egg collection, create embryos, freeze embryos. And then, when your 6-month waiting period is over, then you can embark on the frozen embryo transfer. There are some patients that I recommend waiting for slightly longer when we've had multiple fibroids excised. Then I tell them that they need to wait a little bit longer, than 6 months and then come back. Because for them as well, it is a lot to take on board once they undergo a major surgery. And they need to have some quality of life before they jump onto the next life-changing decision of theirs, that is to have a baby. So it's not easy. It's too many things on their plate. So you must give them time to heal and for the uterus to heal, and then you embark on the pregnancy journey.
Very true. Very nicely you have covered this. So related to this, one more question we have received. The line of treatment post myomectomy is the IUI versus IVF. Which and why?
Um, Actually, I don't even do IUI and IVF. If you've done a neat job at myomectomy and the tubes are patent, I tell patients go and try on your own. And you'll be amazed that almost a third of your patients will go and conceive and come back on their own. You may not need to do anything. It's only then when they don't conceive after at least 6 months of trying, I say, aa jao. And then, of course, the first line of management, if tubes are patent, sperm is decent, you do IUI. And if it doesn't happen, then you move on to IVF. I think IVF has to be the last resort. It cannot be the first resort.
Correct. So, as we have already discussed, the fibroids are mostly benign. So, there is one more question as we have received. Yeah. Any recent medical emerging drug therapies for the fibroid treatment in your experience?
You will just need hormone receptor modulators to help with fibroids. But again, you must see the side effects of all of these drugs on liver, etc., and see how they work in the long run. I mean, we had ulipristal, and then what happened? Then there came a ban on the ulipristal because of the liver damage. So I guess you just need to wait. But the reality is that fibroids are extremely slow growing tumors, very, very slow growing tumors. So, whether you give GnRH analog, which may or may not work, or you give any hormone receptor modulator, it takes time, you know. So I'm not sure how much you need to rush in to do anything for a fibroid because they're really slow growing. And if they are growing fast, then you must have that index of suspicion whether there is a malignant component to the fibroid, which of course is very rare. A sarcoma in a fibroid is less than 1 in 400. So, the realistic chance of a cancer is quite low. But having said that, I had 2 cases recently where really innocent looking fibroids turned out to be sarcomas. And then they had to undergo radical surgery thereafter. So
Correct,
that's luck.
correct. Huh. So our organic branch is totally unpredictable. When the patient,
Yes,
simple patient become complicated, doesn't know when a complicated patient where we are planning, it will take 2, 3 hours. We finish the surgery in half an hour. So our
correct.
branch is totally unpredictable.
True,
Yeah,
true, true.
yeah. Any more questions, Namrata? You are having, please take. Huh.
Yes, we have received one last question, ma'am. The question is, what is your follow-up protocol for myectomy to monitor for recurrence complications?
I generally see my patients once the week after the surgery to make sure all the suture points are okay. And then I see them back after 3 months. And then, of course, if they're interested in fertility, you start them on folic acid and tell them that you can start trying once the 6 months period is over, you can try. And I don't particularly, I mean, I just recommend to all patients that once a year they need to come back for a pelvic ultrasound. I think that is like, checking your sugar, thyroid, all those things. We say na ki annual health check karao, to वैसे annual pelvic ultrasound karao, you know. So it becomes a part of that process. But I don't necessarily kind of start digging and looking for recurrences, because as I said, they are very, very slow growing tumors. And it's not that suddenly one big one will emerge out of nowhere. That very, very rarely happens. So, yeah, once a year is more than sufficient if they are not interested in fertility.
Yes, ma'am.
Correct,
These were
correct.
the questions we have received.
Yeah. Yeah, thank you, Manisha. We are perfectly completing on the time. So whatever the questions we have received, we have discussed all. So
I just want to add one
yeah,
point if there are any students.
yeah,
And
yeah.
if you're doing a laparoscopic myomectomy, please try and do an in-bag morcellation, because any little pieces of fibroid dropped in the peritoneal cavity can cause peritoneal leiomyomatosis. And I recently had a patient who had myomectomy done in the past, and she continued to have heavy bleeding and it wouldn't stop. And finally she said, I've completed childbearing. She was 46 years of age. So she said, do a hysterectomy. So when we did a lap hysterectomy for her, there were so many fibroids, seedling fibroids all across the peritoneal cavity. It was a
Oh,
job to excise those fibroids and bring them out as well, along with the uterus with recurrence of fibroids. So in-bag morcellation when you do a myomectomy is absolutely crucial when you're doing fibroid surgery, if you're doing it laparoscopically or robotically, whatever.
correct, correct. Yeah, thank you for sharing such nice tips. So I think with this we can bind off, Namrata. All the questions are finished now.
Yes.
Yeah, yeah. So
Okay,
thank you
thank
once.
you. This was a wonderful session. Thank you so much
Yeah,
for having me on board.
thank you, Dr. Manisha, having coming with us. Yeah, yeah. Namrata,
Okay.
you can wind up. Yeah,
Yes, ma'am.
yeah, yeah.
Yes. Thank you, Dr. Manisha Singh and Dr. Ritu Santwani, for an insightful and clinically relevant session on managing fibroids and reproductive years. Your expert perspectives have brought much needed clarity to this complex subject, enriching the understanding of many practicing clinicians. We deeply appreciate the time and expertise you've shared with MediSage community today. And to our viewers, thank you for joining us. And we hope this Medtalk has enriched your understanding and sparked important conversations around patient education. And those who missed the session, it will be available in the past event section. So please do watch it. So until next time, stay tuned, stay informed, and stay empowered. Good night.
Thank you. Take care.
Good
Bye-bye.
night.
Take care. Good
Thank you.
night.
Bye-bye. Good night.